This is Nursing 203. We'll be discussing Module A, Cardiac Alterations. In this section, we're going to be discussing pacemakers. Your reading assignment for pacemakers is your IGGY book, Med-Surg book, Critical Thinking for Collaborative Care, 6th edition, pages 750 through 761. Tabers also has good definitions of different terms we'll be using during this lecture. If you have a Linton, you can also use pages 648 to 650. So our objectives are to discuss what is a pacemaker, what are the indications for pacemaker, what are the different types of pacemakers, why should a pacemaker sense the electrical activity of the heart, what is the NGB code and what is it used for, and what are the most common pacemaker modes. And that is talking about not only temporary but permanent pacemakers. Some of the terminology that we'll be talking about are leads, demand pacing, synchronous pacing, asynchronous pacing, capture, oversensing, undersensing, and dual chamber. We'll talk about the NGB codes, VOO, VVI, AAI, and DDD. So what are the indications for a pacemaker? Indications for a pacemaker is typically a bradycardic rhythm which is not meeting the metabolic demands of the body. The typical type things that we're going to see that require a pacemaker are two basic rhythms. One is a Mobitz type 2 second degree heart block. The other is a third degree or a complete heart block, as illustrated by the two rhythm strips. The top strip is the Mobitz type 2. The second strip is the complete heart block. So let's talk about another type of heart block which can progress into the Mobitz 2 but typically does not require pacemaking, but I do want you to know about, and that's called the second degree AV block, Winky block, or Mobitz type 1. Mobitz type 1. The etiology of this type rhythm can be from an MI, electrical imbalance, acute rheumatic infections, myocarditis, drug toxicities with medications such as digoxin, beta blockers, or calcium channel blockers. We treat this typically by monitoring. We hope that this rhythm will revert back to a normal rhythm. This rhythm can progress into a more ominous type rhythm, such as a Mobitz type 2 second degree AV block, or to a complete heart block. So monitoring is one of the big things that we do for this rhythm. So what defines this second degree AV block, Winky block, Mobitz type 1? Well, as we begin to look at our rhythm strips, let's remember to use our 5-step method of looking at our rhythms. Let's look at our rate. Typically our atrial rate is greater than the ventricular rate, but both are usually within normal ranges of 60 to 100 beats per minute. The rhythm, atrial rhythm, is typically regular. The ventricular rhythm, though, is irregular. When we look at our P waves, they are typically upright, normal in size and configuration. We look at our PR interval. This is what distinguishes this rhythm. Our PR interval lengthens with each cycle until a P wave appears without a QRS complex. Then the cycle begins. This is Nursing 203. We'll be discussing Module A, Cardiac Alterations. This particular section will be talking about pacemakers. Here's your required reading, your IGGY book, pages 750 through 761. Your Taber's Medical Dictionary has great definitions of the pacemaker and the different modes of pacemakers. If you still have your Linton, you can look into 4th edition, looking at pages 648 to 650, has also information on pacemakers. Our objectives for this section is to define what is a pacemaker, determine what are the indications for the pacemaker, to look at what are the different types of pacemakers, why should a pacemaker sense electrical activity, what is the NGB code and what is it used for, what are the most common pacemaker modules. I apologize, I'm using a laptop that I'm not accustomed to using to record this. So as we look at pacemaker terminology, we're going to be looking at leads, demand pacing, synchronous pacing, asynchronous pacing, capture, oversensing, undersensing, talking about dual chambers. We're going to look at the NGB code, and under those code we're going to look at VOO, VVI, AAI, and DDD. So what are the indications of a pacemaker? Typically the indications of a pacemaker are any type of bradycardic arrhythmia that is not meeting the metabolic demands of the heart. The two major rhythms that we're going to be discussing and looking at that require a pacemaker is a Mobitz type 2 second degree AV block, which is your top strip, and a third degree or complete AV block, which is your bottom strip. Now there is another second degree AV block that I wish to discuss with you, because this can progress into a third degree or a second degree Mobitz type 2 block. And this is the second degree AV block or Wiki block Mobitz type 1. Mobitz type 1. Etiology of a Mobitz type 1 can be from an MI, electrolyte imbalance, acute rheumatic infections, myocarditis, drug toxicity from digoxin, beta blockers, or calcium channel blockers. Treatment typically is monitoring for these patients. This rhythm typically will meet the metabolic demands of the body, but it actually can progress into a more ominous type rhythm, such as the third degree AV block or the Mobitz type 2 second degree AV block. So our job with this patient is to monitor them to see if either they go back to a normal rhythm or move forward to a worse rhythm. So what are the hallmarks that describe a second degree AV block Winky block Mobitz type 1 rhythm? Well, as all rhythm strips, let's go back and look at our rhythm strip just as we always do. Let's look at the rate. Typically our atrial rate is greater than the ventricular rate, but both rates are usually within 60 to 100 beats per minute. The rhythm, atrial rhythm, is regular. The ventricular rhythm happens to be irregular in this case, though. The P wave is upright, normal in size and configuration. Here's the defining factor of this Winky block or Mobitz type 2, is the PR interval. The PR interval lengthens with each cycle until a P wave appears without a QRS complex. Then the cycle begins over again. If you look at the first QRS complex and then move to the right, you will see a P wave. That P wave does not have a QRS complex. There is a dropped beat. Then let's look at the next cycle. We have a P wave, a PR interval. We got QRS, and we have another P wave and a PR interval. As you can see, this PR interval is longer than the one before it. We go to the next one, we have a P wave, and you can see this PR interval is longer than the one before it. So they continually just get a little bit longer, a little bit longer. Finally, what happens is we have a P wave, and then there is no QRS complex. This P wave, or this electrical activity from the SA node, is blocked at the AV node. The body will then just reset the mechanism and start over again. And so you will have basically a PR interval getting longer, 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 and longer. And probably if the strip continued, the next thing we would see is a P wave without a QRS complex. So the defining factors of this Winky block Mobitz type 1 are PR intervals that continually get longer until a QRS is dropped. There is a blockage at the AV node that's not allowing one of the PR or one of the P waves to go through the system. So there's a block at the AV node. The other rhythm that we're going to look at is a second degree AV block Mobitz type 2. Second degree AV block Mobitz type 2. Again, as we look at these rhythm strips, let's look at our rate. Usually the rate is within normal limits. Note that the ventricular rate is less than the atrial rate. If we look at the rhythm, The atrial rhythm is regular. The P-to-P intervals are regular. Now the ventricular rhythm can be either regular or irregular. If you look at the strip that we have here, you will notice that the R to R's are equal and we have a regular ventricular rhythm. Let's look at our P waves. P waves are typically upright, consistent in configuration, but not all P waves are followed by a QRS complex. Again, not all P waves are followed by a QRS complex. So we can see a P wave, QRS, P wave, no QRS, P wave, QRS, P wave, no QRS. The PR intervals may be normal or prolonged, but are consistent on the conducted QRS complexes. If we measured the PR interval here, 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 or here, then we would see that PR interval is consistent. Each time there is a conduction of that P wave, the PR interval is going to be normal. Now, this is a Mobitz Type 2 second degree AV block. It is a 2-to-1 block. 2-to-1 meaning that there is 2 P waves for each QRS. 2 P waves for each QRS. So this is a second degree AV block, Mobitz Type 2. The cause of the Mobitz 2 are basically just like for a Mobitz Type 1, the MI, the electrical imbalances, acute rheumatic infections, drug toxicities, myocarditis. Treatment, though, varies, is different here because typically, as you saw in this rhythm strip, the ventricular rate is slow. In this particular strip, we're probably looking somewhere between 45 and 50 beats per minute. This may not be enough cardiac output to sustain the metabolic needs of this patient. So if this patient is symptomatic, by symptomatic we mean changes in level of consciousness, decreased blood pressure, decreased urine output, any of those things that would indicate a decreased cardiac output, then we need to treat this patient. The initial treatment would be with atropine IV push to help maintain that rhythm. Eventually we want to try to maintain this rhythm. Atropine, we can only give a total of 2 milligrams of atropine. That's 4 doses of atropine that can be given. This patient may require a pacemaker in an emergent situation. In this emergent situation, we can either use a transcutaneous pacemaker or we can use a transvenous pacemaker depending on the location of the patient. Transcutaneous pacemakers are more likely going to be used in the emergency rooms. Transcutaneous pacers, as I was saying, typically are used in emergency departments or on ambulances to be used in the field. Transvenous pacing is more used in your critical care areas to maintain the patient until a permanent pacemaker can be established. There is also other types of pacemaking that we will talk about, but for the Mobitz Type 2, those are the ones we're going to be looking at the most. Now, complete heart block or third degree heart block is where there is a total dissociation between the SA node and the AV node, or the rest of the heart. Basically, at the AV node, the impulse is being stopped. So you have the SA node firing, it goes down to the AV node, but does not proceed any further. So the ventricles are not stimulated by the electrical activity that's started by the SA node. When we look at our rhythm strip for a complete heart block, we're going to look first at the rate. Typically, our atrial rate is normally 60 to 100 beats per minute. The ventricular rate is going to be dependent on the area that's initiating the impulse. Typically, it's going to be less than 45 beats per minute because in many times this is not coming from the junctional but becoming somewhere in the Purkinje or maybe even the ventricles that are initiating the initiating area for the rhythm. If we look at our P waves, our P to P intervals are going to be regular and our R to R intervals are going to be regular. But the one thing that you'll have to notice, there is no relationship between the P waves and the QRS complexes. So if we look at our PR interval, they're variable. There is no relationship of the P to the QRS. If you measured each PR interval throughout a strip, there would be a difference in each PR interval. They would not be the same. If you took your piece of paper or your calipers and marched out the two separate components of the strip, your P waves and your QRS, your P waves would march out and be regular, and your Q waves, QRS, would be march out and be regular. But again, there is no association between the P waves and the QRS. That is why it's called a complete heart block or a third-degree heart block. So basically, with the third-degree heart block, you don't have your SA node fires, P waves are generated, the atrial contract, but there is no stimulus getting through the AV node to cause the ventricles to contract. So as you look at this, in most cases you're losing that synchronization between the atrium and the ventricles. Therefore you're losing a lot of cardiac output because of the atrial kick. Also look at the ventricular rate. The rate is very slow. This slow most likely will not be able to meet the metabolic demands of the body. Typically this is an emergent situation that requires treatment rapidly. Again, the causes of the third degree AV block can be ischemia or damage to the AV node. That can be associated with an inferior or an anterior septal MI. It can be degeneration of the conduction system. As we get older, things begin to deteriorate. Cardiac surgery is typically one of the big things. We'll see this with cardiac surgery, especially our bypass graft patients and with our valve patients. Many times we plan ahead for this by actually putting in something called epicardial pacing wires. And Ms. Lee will talk a little more about that as she talks about coronary artery bypass graft. Again, drug toxicity with the digoxins, the calcium channel blockers, the beta blockers actually can cause this as well. Treatment for this basically is a pacemaker. These patients need a pacemaker. It may just be temporary, but typically these patients are going to require a permanent pacemaker to maintain their heart rate. So, just a review, what are the indications for pacemakers? One is a second degree AV block, Mobitz type 2, a complete heart block, third degree heart block. Now there are a few other causes that we can talk about. There's something called sick sinus syndrome, in which the sinus node is not functioning properly and not firing as it needs to. In some cases we'll put in a pacemaker for those. We can put in a pacemaker for any reason that the heart cannot maintain a rate that can meet the output demands or the metabolic demands of the body. We see that a lot of times in our patients who have cardiomyopathy or have problems with the heart, especially our congestive heart failure patients. Many times they'll put in a pacemaker to try to keep the rate up enough to keep the cardiac output up. Remember that cardiac output is a function of stroke volume times heart rate. So if we can get the heart rate up, maybe we can increase that cardiac output. You will see pacing, especially transcutaneous pacing, used in codes when patients are asystolic, when they do not have a heart rate at all. As a last-ditch effort, many times these patients will be hooked up to a transcutaneous pacer to see if you can pace them and get a rhythm for these patients. So as we continue, these are the different things. I'm sorry I went on. The other thing that we see sometimes is our patients who have atrial fibrillation with a rapid ventricular response. In many cases, we can't convert these patients from that atrial fib rhythm, so we have to do something to block that rapid ventricular response. And what the cardiologist will do, they will go in and use an electrical stimulus and actually burn or ablate that pathway for that irregular rhythm. Sometimes this totally wipes out the whole electrical system of the upper heart. So these patients will require a pacemaker to keep their rate up and maintain their cardiac output. We talked about sick sinus syndrome, we talked about bypass surgery, valve surgery, and when the demands can't be met. So what are our options for pacing? When we have a patient that requires a pacemaker, we look at either temporary or we'll look at permanent pacing. When we look at temporary, typically we're going to be talking about transcutaneous or invasive. Now we're going to talk more about on the invasive side. Our focus is going to be on transvenous pacing. We'll talk a little bit about epicardial pacing. Epicardial pacing is an invasive type pacing that is usually done when a patient has had heart surgery. The epicardial pacing wires are sewn directly to the ventricles of the heart and left in place for a short period of time so the patient can heal from that bypass or valve surgery. It is used in those cases to treat dysrhythmias of that patient. It can be used to treat rapid rhythms, can be treated to treat blocks. So typically you will see that on our patients who have coronary artery bypass graft or have valve surgery. You'll see the epicardial. Don't see the transesophageal much, but it is something that's out there. So how do we decide whether we're going to use transcutaneous or invasive pacing? That basically is going to be dependent on the situation and what you have available. Again, we talked about the transvenous pacing. It's going to be more in your critical care areas, where your transcutaneous pacing is going to be more in your emergency rooms and on your ambulances to be used as a part of the ACLS treatment for patients with cardiac issues. Let's take a quick look at some transcutaneous pacing units. These are a couple of different types. The one on the left is a Zoll transcutaneous pacer, something that's been out for many years. Hopefully we'll get a chance to show you guys a LifePak 12 with a pacer built in. So once we've determined that a pacer is needed for the patient, how are we going to initiate this transcutaneous pacing for that patient? Of course, we're going to determine the need. If that patient has a need of bradydysrhythmia and cannot meet the metabolic needs with that rate, then we need to go ahead and apply this pacemaker. With this transcutaneous pacer, we definitely want to inform the patient that we're going to be applying this pacemaker. This pacemaker can be very, very painful, so we want to make sure they understand what we're doing and why we're doing it. We're going to cleanse that patient. Your book talks about you want to clean the site with soap and water if time allows. They do not recommend shaving the site of excess hair, but in clinical experience tells me if you have a patient that is very hairy, many times we will go ahead and clip the hairs if possible to allow the pad to adhere better. If we do not get good adherence of the pad to the skin, we may not get good capture from the pacemaker. The pads will be applied, and I will show you a slide of the pads being applied in a moment. Look at your machine wherever you're working. Take a look at your defibrillator, pacemaker, monitor system. Look and read and look over. It should tell you exactly how to apply the pads. Make sure you understand that. Wherever you go, you want to. That's one of the things you want to do, is understand how to use the equipment that's there. One of the other things with this is you don't want to apply it over the female breast. Move the breast tissue to the side or up and put the pad underneath that tissue. The more tissue this electrical activity has to go through, the greater the chance that we will not get captured. So once we have the pads on, then we're going to set up the machine. First thing we're going to do is set the rate. Now the rate will be determined by the physician. Here's a quick look at how the pads will be set up for that Zoll machine we're looking at. And most of the other ones are going to be very similar. So what we're going to do with this, once we get the pads on, we're going to turn on the machine. You can see the green button at the top on this particular one. This happens to be a LifePak 12. You can see the green button. That turns the machine on. Once you go down, you want to then hit the pacer button. The pacer button will turn the pacemaker on. If you can see at the very top, it tells you basically how to do it. Push pacer, turn pacer to on. Push rate button and adjust up or down as needed. Now the physician will determine the rate. Typically we're going to start out at a rate of somewhere around between 60 and 80, and that's going to depend on what's going on with the patient at that time. If their rate's already 60 and they're not meeting the demands, then we're probably going to go up to 70 or 80. Once we have the rate set, then we're going to select the current. The current is measured in milliamps. The milliamps is the amount of electricity that is required to cause a stimulation of the heart. Okay, so basically we're going to set the rate. As you can see on this slide, the rate is set at 60 per minute, and you can see in the corner here where it tells you how many milliamps. And we don't have anything set yet. So at that point, you would have, once you've got the rate set, the machine should start firing at rate of 60 spikes per minute, or 60 stimulations per minute. Now what we're going to do is then we're going to take the dial or the button, and we're going to start going up with a number of milliamps. Okay, we're going to continue to go up until we see capture. Capture means that as you see a pacemaker spike, you see directly following that pacemaker spike, you see a QRS complex. I have slides that will show you what a capture looks like in a few moments. But once you get capture, once you're getting consistent capture with that number of milliamps, you're going to go up, your book says, by 2 more milliamps and maintain it at that portion. Now you want to continually monitor your patient to make sure that you continue to get capture. One of the things that can happen is the longer this is in place, resistance can increase, and the amount of amperage needed to maintain the paced rhythm may go up. So it's your job as a nurse to continually monitor that patient to ensure that you're getting capture and that you're meeting the demands of the body. Okay, again, there's that one. So let's just talk about just quickly a brief summary of what we've talked about with transcutaneous pacing. We're going to look at the indications, emergent pacing until more permanent methods can be established. That's why we would use the transcutaneous pacing. The procedure, we're going to apply the posterior pad between the spine and the left scapula. We're going to put the anterior pad typically in the areas of the V2, V5 areas. Those are the areas we talked about applying EKG leads. We want to set the desired rate on the machine, and most of the time that's going to be physician directed. And then we're going to start increasing the amperage or the output until capture is achieved. Once capture is achieved, we're going to go up by at least 2 more milliamps to assure that we continue capture. Complications of transcutaneous pacing: pain is the #1 thing. Okay, this is very uncomfortable. As that sends an electrical shock through the body, it's going from the front to the back. You're going to get muscle contraction. That muscle contraction is going to cause pain. We can get loss of capture. Loss of capture basically means that the pacemaker is still firing, but we're not getting a QRS for that. That can be because the pads have come loose, can be that we need to increase the amperage. It can be several things that we're looking at. And unfortunately, it can be dead heart tissue that just won't deliver or capture an electrical activity anymore. And then we can have inappropriate pacing. We may not have that set in the right area. We can get stimulation of the diaphragmatic nerve. So we have to be careful and watch for those. The other thing that's not listed here is you can actually get skin burns, okay, from these patients if you have to turn the amperage up high enough. The larger the patient, the more amperage typically it's going to take to achieve capture. So the greater risk there is for burns to the skin, and the greater risk there is for pain for these patients. So transcutaneous pacing is more an emergent type thing used in the emergency room and on ambulances until a more definitive type of care can be established. Many times these patients will come into our critical care units on a transcutaneous pacer until we can get transvenous pacing established. So let's talk a little bit about invasive temporary pacing. Invasive temporary pacing basically requires the insertion of a large catheter, so that a large bore cordis or needle, so that a catheter or a wire can be passed through it to go directly to the heart muscle. With this transvenous pacing or invasive temporary pacing, the physician will insert a large catheter into a large vein. Usually it can be in the internal jugular or subclavian. You can sometimes go through the brachial, but many times you want to avoid the brachial because of the patient bending the arm. Once this cordis or large catheter, guide catheter, is in place, then the pacing wire is threaded through the catheter and directed toward the right atrium and the right ventricle. The goal is to attach the catheter at the area of the right ventricle to stimulate the right ventricle to contract. On the end that's outside are two metal pins. One's a positive pin and one is a negative pin, and those will attach to a pacemaker generator. The generator is what delivers the electrical activity to the heart. What we hope is that this catheter will remain in contact with the cardiac muscle and actually stimulate the muscle to contract. Now, this works much better than transcutaneous pacing. It takes much less electricity. It is not painful to the patient in most cases. They do not feel this. The biggest problem is that it is a invasive type procedure. This particular one you're seeing here actually has a little helix type screw on it that actually is actually dug into the heart muscle, allowing it to stay in contact with the heart muscle better. The newer ones don't necessarily have that. It depends on which company you're doing. The one we have that I could show you at school actually has a balloon that allows it to float in easier and then just hopefully remains in contact then with the right ventricle. What are some of the problems with this type of pacing? Well, let me back up. Here are a couple of different types of the pacemaker generators. The one on the left is, of course, the newer one that's more digitalized. Everything is there and push button, easy for you to use. The one on the right hand side is an old type that basically is very similar. I mean, will do the same thing, but you can see you have knobs to set the rate and the output and the sensitivity. The big problem with the one on the right is the knobs can get turned too easily, and you can have problems. The rate can go up or down, so you have to be very careful with those type pacemakers that the rate does not get changed. These, again, you can see at the top of this one, these would be where the wires would connect, the positive and negative. On the digital one, they're more in the back here. You really can't see it. The new digital type ones actually have shielded, or designed for shielded leads, so that you don't have to worry about something called microshock. With the old ones, you had to have a bare metal tip on the pacemaker wire or lead that's going into the heart. You could actually cause a patient to go into ventricular fibrillation through something called microshock. If you've ever walked across a carpet and then touched someone and shocked them with static electricity, that's what can happen with these open-ended wires. If you accidentally touched one of those open-ended wires, pacemaker wires, and had static electricity discharged from you into those wires, because this is in direct contact with the heart, it only takes a small amount of amperage to actually put this patient into ventricular fibrillation. So one of the big problems with temporary pacing, whether it be transvenous, as we're talking about here, or epicardial, which we'll talk about with our bypass patients, is the fact that microshock can can be an issue. You have to insulate these wires, preventing microshock. Your book will talk about actually putting a glove, rubber glove, or fingers of these rubber latex gloves over these wires to prevent that microshock effect. So, as we look at invasive temporary pacing, typically transvenous pacing is what I'm concerned about more. Here are the biggest problems that we'll see. Of course, you can have infection at the site if it stays in long enough. You always have to worry about infection anytime you break the skin. You can also get a hematoma at the insertion site, especially with the subclavian type approaches. You can get ectopic complexes. Because this pacer wire is moving around within the ventricle, you can develop PVCs from it. Because if the patient moves or turns, you can get loss of capture. Loss of capture means the pacer is still firing, but basically that the heart is not capturing that electrical activity, so you're not getting a QRS complex. You can have problems with over and under sensing, and we'll talk more about that. One of the things is you can get diaphragmatic stimulation. If you're having to go up high enough on the amperage to get capture, you can that amperage sometimes will go down to the diaphragm and cause the patient to almost hiccup every time that pacemaker fires. That is very disturbing for the patient. And then we talked about microshock. Now, the definitive type treatment for our patients with complete heart block or with any of these Brady dysrhythmias that are not meeting demand is permanent pacemakers. The epicardial or surgical approach is not used very much anymore. It is used occasionally, but very rarely is it used. Most pacemakers now are endocardial, or the transvenous approach, where the pacemaker is actually placed through a vessel, through a major vein, and then directly into the heart. This is done typically in the cardiac cath lab at Huntsville Hospital. A opening is created in the skin to place the pulse generator. Then the wires are run through the venous system to the right ventricle. Now, there are new ones that actually will go both right and left ventricle leads to give a better synchronization of the two ventricles to get better cardiac output. Okay, this is typically what the permanent pacemaker consists of. Consists of a pulse generator that basically houses the battery in a small computer. Pulse generators have gotten much smaller over the years, much easier, much smaller, and more compact and more sophisticated as we go along. There are lead wires again that we're talking about are run through the veins into the right ventricle to get capture into the right ventricle. Typically, most of them are both ventricular and atrial devices that will stimulate both the atrium and the ventricle, and also will sense from both the atrial and ventricle. Newer ones are actually going across and actually doing not only right but left side again to synchronize these rhythms. As you can see here in this depiction, that basically the pacemaker is there. The wires go through the subclavian into the right atrium and then into the right ventricle. These are just a couple of different types of pacemakers that you could see. Sorry that you can't touch them, but believe me, these are not much bigger than $50 in size as you compare them. So when we start looking at pacemakers, they're basically the North American Society of Pacing and Electrophysiology, along with the British Pacing Group, has devised a code for identifying the capabilities of pacemakers. This is called the NGB code, and that typically consists of 5 letters. But what we're going to be concerned about are the first 3 letters. Those are the ones I want you to have a little bit of understanding about what they mean. Okay, the first letter of the NGB code tells which chamber the lead wires are located, therefore which chambers are paced. As you would suspect, A is for atrium, V is for ventricle, D is for both chambers, and 0 or O is for none, or not into that chamber at all. Okay, the second letter is for the chamber that is sensed. Pacemakers need to sense the heart's normal electrical activity. It is very important that the pacemaker sense the electrical activity. You do not want that pacemaker firing when the heart is firing its own electrical system. What can happen is you can have the pacemaker fire, and it will fire on that vulnerable area. Remember, we talked about an R on T phenomenon. So if it fired a pacemaker spike right on that T wave in that vulnerable area, you could put that patient into a ventricular tachycardia or ventricular fibrillation. So we want these pacemakers to sense the heart's activity and not fire when the heart is firing, but also be triggered when that area is not firing. So the second letter is for the chamber that's sensed. As before, A is for atrium, V for ventricle, D for both chambers, 0 for none. The third letter describes what the pacemaker does when it senses a naturally occurring stimulus, whether it's a P wave or a QRS. I is for inhibited, meaning it basically does not fire when it sees it. T is for triggered. So if it doesn't sense one, then basically it will fire. Okay, D is for both inhibited and triggered, and 0 means it's asynchronous. Asynchronous means that it is set to fire at a certain rate, whether it be 60, 70 times per minute. Whatever the rate is set for, that pacemaker will deliver an electrical activity, an electrical spike at that preset time. So if it is set at 60 beats per minute, every second that pacemaker is going to fire, no matter what the heart itself is doing. Now, when we talk about triggered basically allows for the maximization of the heart's natural function. If the pacer doesn't sense an atrial beat within a programmed amount of time, it'll fire, causing the atrium to contract, taking advantage of the atrial kick. Same thing if it's in the ventricles or whatever. But basically, typically what we're seeing these days are DDD pacemakers. So it's pacing in both chambers of the heart, it's sensing in both chambers of the heart, and it also can inhibit or it can be triggered to fire a stimulus. Common pacemaker settings you're going to see are VOO, and that's typically only the ventricles are paced. It's called asynchronous pacing or competitive, as that pacemaker will fire at that predetermined rate. So this is asynchronous pacing. VVI, or demand pacing, paces only the ventricles but senses what is happening in the ventricles. If it senses stimulus, whether it's a normal beat or PVC, even VTAC, it will not fire. AAI is also demand pacing, but it works just in the atrium. The DDD senses and paces both the atrium and the ventricles. In this mode, the atrium leads look for normal impulses. If nothing is sensed, then it will fire stimulus to the atrium. The ventricular lead is sensing the ventricle. If the pacemaker has not sensed an atrial stimulus or has fired or waits for a QS to occur, if it does not occur within a pre-programmed time frame, the pacemaker will stimulate the ventricle to fire. It preserves basically the atrial kick. So what the DDD is doing is trying to make sure that we'll get an atrial firing to get the atrium to fire, and then it waits so long, and hopefully that it will stimulate its own ventricular rate. But if it doesn't, it will fire, and therefore you get the atrial kick type process. So what are some of the complications of permanent pacemakers? Well, of course, anytime you have anything that's invasive, remember that pacemaker generator is actually placed in a pocket just under the skin, and then has leads that go into the venous system. So we can have infection at the surgical incision. That's more of a topical, or more a infection more at the upper level. you can get infections even down into the generator pocket. These are much more problematic. It is very, very hard to heal. In most cases, if you get infection in that generator pocket, that pacemaker generator has to be removed from that area and then a new one placed in another area. Failure to capture, oversensing, failure to fire, and undersensing. I'm going to discuss a little bit more per se in each of their own little slides. Failure to fire is where the pacemaker has been firing and then for some reason stops firing. What happens, if you notice on this particular strip, you can see the atrial pacemaking spike and the ventricular pacemaking spike. It is fired for two complexes, but then all of a sudden there is no pacemaker spikes. But if you look at this rhythm, you can see this is a very bradycardic type rhythm, and that pacemaker should be firing. This failure to fire can be from lack of battery. The battery is run down. It could be the fact that the leads have come loose from the pacemaker itself. It could be that the amperage, if we're looking at a temporary type pacemaker, that the amperage has got turned down and we need to increase the amperage, or it got turned off. Got to take a look at this patient, see what's going on. Your main priority is this patient because you've lost most of your cardiac output. You've got a very bradyc arrhythmia, and you want to try to see what you need to do with that patient. Take a look at your patient, try to diagnose what's going on with that pacemaker while trying to maintain and support the cardiac output for that patient. The other one is called failure to capture. Failure to capture. Failure to capture is where you have a pacemaker, the pacemaker is firing, but there is no QRS complex following that pacemaker. You can see here you've got a pacemaker spike, but you have a QRS after that. Well, here you have a pacemaker, no QRS, pacemaker, no QRS, pacemaker, no QRS, pacemaker, no QRS. Typically, this pacemakers are firing appropriately, but for some reason the cardiac tissue is not responding to that electrical stimulus. It can be from too little amperage being delivered, whether it be transvenous or transcutaneous. For a permanent pacemaker, it could be scar tissue at the site. It can be from a dislodged lead that's not in contact with the myocardium. It can be caused by medications or electrolyte imbalances. But again, very easy to identify this particular type because you have seen capture. See capture here, but then you have pacemaker spikes and no capture. Take a look here. We had a problem over this way. We had a pacemaker spike, but it really didn't capture here, and we had the body's own QRS, but here the kick back in, and it's firing again at its own rate. So there is something going on unusual with this patient. But failure to capture is where you see a pacemaker spike and there's no QRS, as compared to failure to fire, where we don't see a pacemaker spike and we see the body's own intrinsic rhythm beginning to take over. Oversensing is where the pacemaker is actually sensing something other than the QRS. In this particular rhythm strip, this person's pacemaker is programmed to beat at 75 beats per minute, or 800 milliseconds between beats. If we look, this pacemaker is actually sensing this elevated ST segment as a QRS, so it is not firing at its programmed rate. So instead of it firing where it should about here, what it has done is sense this as a QRS and did not fire. So if we look at this rhythm strip, we've got a rate of 1, 2, 3, 4, a rate of right around 50 beats per minute, somewhere between 45 and 50 beats per minute. So this pacemaker is not firing as it should at 75 beats per minute, but it is sensing. It thinks the heart is beating at a rate of about 190 to 100 beats per minute. So that is oversensing. Undersensing is where it is actually not picking up the heart's normal electrical activity. You have a QRS complex here, but the pacemaker did not sense that and fired. See how that is on the T wave? That could be problems. Again, we have the heart firing. Again, it did not sense, and then basically it fired. Again, the problem with the undersensing is the chance of landing on that ST segment and putting that patient into ventricular fibrillation through what's called the R on T phenomenon. Okay. Some of the things that we really have to worry about with our patients as they begin to go home, if you'll look on page 760, chart 36.7, it's really going to go over the big list of types of patient education that you'll need to provide for your patients who've had a permanent pacemaker placed. We're going to go over wound care with them, about basically how long before they can shower, how long before they can bathe. Once that skin is healed, we can let them know they can shower, bathe, swim without any problems. Talk to them about their activities. Each physician will have a little different on what they want for these patients. Most patients for the first 2 weeks will be having no heavy lifting or no overhead lifting. They want to give that pacemaker time to settle and that surgical site to heal. They're going to limit that range of motion of the arm. Many of them will put the arm in a sling to remind the patients. Most physicians do not want tight clothing or straps over the surgical site, and don't want any type of repetitive or stretching type exercises, especially golf or swimming, for 6 to 8 weeks after the pacemaker's been in place. Normal electrical appliances usually do not affect the pacemaker. The newer microwave ovens tend to not cause any problems, but we still warn patients to be careful because most of them have heard of that, and they're very leery about being around a microwave oven. Cell phones, though, can interfere with a pacemaker. We definitely advise our patients not to carry a cell phone in the shirt pocket near the generator or hold it over the area of the pacemaker. We do want these patients to wear a medical alert bracelet and carry a pacemaker ID card. That pacemaker ID card will describe the type and the settings of the pacemaker. Very, very important. Again, we want these patients to avoid MRIs because of the metal in the pacemaker, and then also because the magnetic properties of the MRI can deprogram the pacemaker. Let patients know they may set off metal detectors in airports, courthouses, or wherever. That's another reason they need to make sure they've got that medical alert bracelet and that pacemaker ID card. So when we talk about pacemakers, we're going to basically we talked about causes, we talked about the different leads, and we talked about the types of pacemaking. There's temporary pacemaking, permanent pacemaking. As we talked about temporary, transcutaneous, transvenous, epicardial. Again, we'll talk more about epicardial pacing as we talk about cardiac surgery, but very, very important. So good luck as you do your studies on pacemakers. Please read your information. There are plenty of articles on the web. If you do a Synol search on pacemakers, you can find plenty of information. Thank you. Also, if you have questions on pacemakers, remember we have set up the discussion pages on Blackboard. So if you have questions or problems or want to have information, please use that discussion session on Blackboard. Thank you.